This lecture then is really a recap in terms of important points from the online lecture that I put on Blackboard for you. But in addition to that, we're going to look at an example case. I'm also going to ask you to work through with me some sample exam questions, because I think sometimes the material's there, but students struggle to sort of think about how they revise and how that translates in terms of answering exam questions. This lecture then is really a recap in terms of important points from the online lecture that I put on Blackboard for you. But in addition to that, we're going to look at an example case. So to move on then in terms of the recap, and I can't emphasize enough the need for yourselves to access the lecture that I put onto Blackboard. So it's really, really important to note that this is merely a recap of material that I've already put in accessible form on Blackboard. But just to say, the whole sort of overall outcome from this learning package, so the lecture now, but also a related workshop that we will do, is to understand patient-centered care as the need to integrate a patient's own experience of health, illness, injury or need with your therapeutic and clinical expertise in caring for and managing them. So one of the concepts that we've got to understand is this notion of the biomedical model. And within this model, so this is a valid model, most of the science teaching that takes place on the module is under the banner of the biomedical model. But here we do look at disease as associated with some very identifiable disturbances to the body, which can be very well measured and defined. And the whole purpose of treatment is then correcting those disturbances. And this has implications in terms of diseases, for example, that are not so hard to measure, not so easy to measure, and not so easy to diagnose. And what this also does is that it sort of almost forces an intervention in terms of a drug or some kind of a mechanical, for example, intervention. So something that's very physical and tangible. But we also know that actually when patients present to us, they present because they've had a subjective experience of their illness. So people might come to your pharmacy or they might visit a doctor because they've actually experienced pain in their physical body, which they've then interpreted in their brain. So there's a cognitive process of thinking about that discomfort or that distress at that subjective level. But people don't live in a sort of isolated bubble, so their reactions to symptoms or the way that they might approach a doctor or what they do in terms of adhering to treatment is informed by social and cultural rules. So you might know, for example, that women are much more likely to see the doctor and to inquire about their health. So then you will see health campaigns that specifically target men because it's recognized that socioculturally men are less likely to seek the advice of a doctor or a pharmacist when they start to experience symptoms. And we also know that people behave in different ways that, for example, increase or decrease their risk of getting ill. So you'll learn about all the modifiable behavior such as smoking, drinking, things that you might also be familiar with, and ways of trying to change people's behavior so that you decrease their chances of getting ill. So we go back to this concept of patient-centered care, which advocates listening to the patient fully and exhibiting care and compassion and engaging in other agreeable behaviours, which means that you invite the patient to talk to you, to share their experiences, so that you can not only gain information from them about how it feels to have that illness, but you can also improve their psychological function as well as their physiological and functional outcomes. Another thing that we covered within the online lecture that you would have accessed already, it's this idea of the placebo effect, which is related to people's psychological responses to medicine. So we know that you can give people completely inert medicines, and this can have a psychological effect on the patient, meaning that actually there is this placebo effect. So you give somebody something completely inert, but it can make them feel better, for example, or it can make them feel that they've suffered some side effects. And this is just one example that illustrates the complexity of people's reaction to health and illness. This lecture then is really a recap in terms of important points from the online lecture that I put on Blackboard for you. But in addition to that, we're going to look at an example case. I'm also going to ask you to work through with me some sample exam questions, because I think the other concept that we covered in the online lecture was this idea of disease versus illness, but also cure versus healing. So to be specific then, it's about looking at the diagnostic process being very much focused on the disease and physical abnormalities that you'll see in the organs and other body systems. And the intention then here is to cure the disease. And you can juxtapose that with that personal experience of the patient who suffers the illness and the impact that that malfunction is having on them, on their social life, on their existence, on their interactions. So really for the patient, it's that process of healing that they go through in order for them to fully return to full health. So again, bearing in mind that this is a recap, and I invite you to go back to the online lectures and the notes that accompany the lecture underneath. We're going to look at materialism and reductionism. So I've said to you that the biomedical model is a perfectly valid model. It's what the sciences are based on, but it is materialist in its nature. So it's based on objective knowledge that we gain using our senses, and it is very much focused on the methods and instruments of obtaining that knowledge. And the theoretical research framework for that is positivism, which means that in order to understand things, events, we need to be able to measure them. And there's always a cause effect. You can always relate in terms of what has caused a specific reaction. And the negative side of this is that this can lead to a reductionist view, which is sort of breaking things down too much into constituent parts instead of considering the whole. And it means that sickness is reduced to malfunctioning elements of the body, cells and molecules, and it does force this idea that you ought to be able to diagnose illness, which is great, but it shouldn't be at the neglect of listening to the stories and the complaints of sufferers. So it can be seen sometimes that doctors are engineers or mechanics there to fix this sort of dysfunctioning body, and that the solution is either in terms of drugs or new body parts. And what we invite you to consider when we talk about a patient-centered care approach to treatment is the biopsychosocial model. And this is looking not only at the biology of the patient, but also their individual psychology and their social circumstances. So this is about a form of holism. This is another term that we mentioned, and it means that when you look at the patient's illness, it's not just about the diagnosis, it's about how they interpret that diagnosis and their journey. So holism is the theory that parts of a whole are in intimate interconnection so that they cannot exist independently of each other. And this is sort of this concept that the whole is regarded as greater than the sum of its parts. So when you are treating a patient, it's about considering everything, not just the specific diagnosis that they've got. As I say, I refer you back to the notes, the audio, and the lecture that's online. So we go back to the notion of patient-centered care, which encourages a focus on patients and their concerns rather than just the disease and its assessment. And practitioners are encouraged to see patients' illnesses through the patient's eyes, to try and experience it from their perspective. And what do we mean by that? It means that on a practical level, you ought to listen and respect patients' beliefs and understand that people's condition can be affected by different socioeconomic circumstances, and those can impact on their knowledge, for example, their health literacy, their beliefs, for example, and therefore their behaviours, their coping mechanisms. And it also actually invites you to understand that patients might not actually want to adhere to treatment. They might well want to follow their own path. So if you're providing patient-centered care at a true level, then you would involve patients in decisions about their care, but also you would respect their decision if it goes against your training even sometimes. And of course, you've got to make sure that patients are consenting to the services that you provide. So I hope that that's given you a quick recap of the material that we covered in the online lecture. And what I wanted to do was just to work through an example, work through a case in order to illustrate those concepts that can seem quite dry in sort of bullet form format. And so what I've done is taken some material from a website. So Health Talk Online exists as a way of being able to deliver the patient's perspective to health professionals. And the area that I focused on is SSRIs. So these are a group of drugs known as selective serotonin reuptake inhibitors. You might have heard of Prozac, for example, which is the brand name for the drug fluoxetine. There are other SSRIs, and these are medicines that are used for a number of conditions, including depression. And what you'll learn about through the course, through your pharmacy course, is a range of knowledge that includes the pharmacology of the drug. So how does it work? So I've already said that it selectively blocks the reuptake of serotonin, and I'll show you a diagram that illustrates that in a bit more detail. And serotonin is a neurotransmitter that results in good emotion, let's put it that way. And we can see in this diagram then that the pink is your SSRI, and it's gone into the synapse there at the top, and it's blocked the reuptake of the serotonin, which are the little globules, so they stay longer in that postsynaptic gap and can have an impact on the synapse underneath on the postsynaptic interface there. So this is how we know the biology of the drug works. So this is how the drug works, and when I've said to you that we want serotonin to be available more because it impacts on good emotion. So the other things that you'll learn about on the course, psychology. And we can carry on, so you might look at the structure of the drug and so on. But what about the patient's experience? Well, when we start to look at what people say when they're taking this medication, we hear some good stories. So, for example, patients describe a wide range of effects, from positive but also to negative effects. So at one end, they talk about SSRIs making them feel fantastic, consistently happy, back to normal. which is great, and that's the effect that you want to have. That's the ideal. So they say suddenly it was like having somebody sort of take charge of you and lift you up. Or I've certainly had dips, but I think I've always managed to get over them, and I've never got in that downward spiral, and this is thanks to the medication. And we've got another example where people try and express their experience of taking their medication. So this person's saying that it takes the edge off their feelings to help them, say, oh, I don't know, normal, but to feel normal emotions in a normal range, and I've got control back. And here's this lady who says that these are her perspective tablets. But also, some people notice differences in the way that they respond to different SSRIs. So you would expect that if you give these medications, that they would have the same effect. And also that the same SSRI can give them a different effect on a different occasion. So there isn't that consistency as such. And not everyone actually knew why their doctor had prescribed one particular type of SSRI over another. And some said maybe they chose that particular SSRI because it suited their symptoms of anxiety or insomnia. And some people thought that their doctors had favourites or suspected that they prescribed the cheapest rather than the most effective. And you can start to see that actually if people are forming these notions in their mind about the medication, then your job as a future pharmacist is going to involve gathering these views and then trying to provide an explanation, maybe correcting some of these misconceptions. And sometimes people experience contradictory effects, so feeling better in some respects but worse in other respects. So for example, here's somebody saying that they felt distant, numb, unable to experience emotions while taking an SSRI. You say you're making it through the day, but you're not living, you're not being you. And others saying actually the drugs made them feel detached. So while some people said that this made them feel that they got a clearer perspective on their life, others said that it gave them a feeling that they were distant from the world and what was happening around them. Here's another example, in fact the final example. So this is Thomas, who took citalopram for about a year but eventually decided to stop because they said, I couldn't think that it had improved my mood and it hadn't done anything for me. And there's another example of Roshin who tried a variety of SSRI but said that nothing seemed to work. So you can start to see that actually things are sort of more complex than we present it at that biological level, and your job then as a pharmacist is to be able to gain these insights in order that you may help patients, but also maybe sometimes agree with them, but sometimes correct their misconceptions. So the accounts tell us that there is a valid patient experience and that as pharmacists, it's absolutely your job to be able to get that perspective and be able to see the experience through the patient's eyes. And when we collate the sort of stories, we can see that some people come to rely on medication for their everyday life. Some people form certain expectations, whether they're reasonable or not. Some people trade off between no depression and no emotion or detachment. So, which would they rather have? Or a feeling that they're not really living. And actually, some people think that the positive effect wears off after a while. So this is a list that goes on. Everybody has a different experience, and it's about finding a way to communicate and be able to get those stories for your own practice. Okay, so far I've recapped on the online material. I've given you an example, and what I promised to do was to also work through some sample questions just to give you an idea of the way in which this particular lecture or this breadth of material will be examined. So in the exam, you would likely be asked either a single best multiple choice question, and I'll show you an example, a few examples of those, or a short answer question which is worth 5 or 10 marks. Now remember that I'm going to put a screencast of this lecture on Blackboard for you as well. So for now, if you just want to focus on this question, which is describe what you understand by the concept of patient-centered care, worth 5 marks. So when you look at this, it's about trying to not write a huge long essay. Okay, so it's just 5 marks worth of an answer. And the other thing that I would urge you to look at is the sort of the verb, the descriptor. So we've got describe what you understand. So at a first year level, it is very much about those learning outcomes, which would normally focus on recounting, retelling, describing, defining, and so on. So we're not expecting you in this question to do anything particularly complex. And so an example of an indicative answer would be, as I've put on the board, so this is trying to think of 5 points that you are making in order to be able to answer this question. This lecture then is really a recap in terms of important points from the online lecture that I put on Blackboard for you. But in addition to that, we're going to look at an example case. I'm also going to ask you to work through with me some sample exam questions, because I think sometimes the materials there, that students struggle to sort of think about how they revise and how that translates in terms of answering exam questions. So to move on then, in terms of the recap, now, here we are. I said to you, a single best answer, multiple choice question. But actually, when you look on the board, this isn't just a one-line question. Actually, you're being asked to read a short case, and you're being asked to actually consider it to gain 1 point. Okay, so again, sort of might be about exam technique, but here I am going to read you through this case. So this is about Mrs. Bannister, who's a self-confessed chocoholic, has been prescribed medication for toothache. She's lost the filling, can't get an appointment at her dentist's practice until the following week. Although she judges her case to be severe and urgent, the dentist practice has assessed the need as non-urgent, and they've prescribed some painkillers for her. They get to your pharmacy and they explain that they don't believe in strong painkillers and they want to buy some clove oil on the recommendation of their aunt. You know that people do purchase clove oil, but you wonder if Mrs. Bannister is right in refusing to have her medication dispensed. Now, the reason I put this on the board is that what you'll find is that obviously you get teaching across a number of lectures, so some of the answers there relate, for example, to another lecture that I might give you, which would be on adherence. In this particular instance, the answer that I would select would be patient-centered care as the priority. Okay, so what you'll find with the single best answer questions is that none of those questions might necessarily be wrong. It's just about prioritizing which one is most correct. This lecture then is really a recap. So I'm giving you here another example of a short answer question, and I've said describe what you understand. So again, it's describe, the verb there is describe what you understand by the concept of a placebo-controlled trial. Now you can see that here you're being asked a question that attracts 10 marks, and you can see that this isn't merely about conveying the concept of what a placebo is, but we've actually asked you what a placebo-controlled drug trial is. And although I didn't cover this in my recap, this material is in the online lecture. So the answer that, again, is indicative is about providing sort of an elaboration in terms of working up to what a placebo is, and then what a placebo-controlled drug trial might be. And so in that way, you can see that that's how you would gain your 10 marks. So hopefully I've illustrated to you the difference between a 5-mark question and a 10-mark question. Again, not inviting a huge long essay, but certainly this answer would be more in depth and longer than a 5-mark question. Okay, I think I've got a couple more examples to go through. Again, you can see that this is a single best MCQ, and I won't read it necessarily, but you can see there that I've asked sort of which model we should be working to when it comes to considering Ethan's case, and you won't be surprised that it's the biopsychosocial model based on the topic of this lecture. So perhaps this one is a bit of an easy question and not one that we would necessarily have in the exam. Here's another, just to kind of cement that difference between a 5-mark and a 10-mark question. Again, we can see define cure versus healing according to the biopsychosocial model. So all you have to do in this particular instance is to give a definition for what you mean by cure, and then to give a definition for what we mean by healing, and make sure that you've got 5 points there that you've articulated. I obviously got way more questions than I thought, so I think this is the final one now. So let's see if we can answer this one together. So Manpreet has been feeling ill for quite some time. She's seen the doctor. She's seen doctor after doctor, but is yet to receive a diagnosis. She complains that none of the tests completed to date have proved conclusive about the cause of her symptoms. As a pharmacist, you know that some conditions are difficult to manage well if the medical team takes a purely reductionist approach. What's the most likely consequence of taking a reductionist approach when dealing with Manpreet? So the options there are: the patient's psychological well-being is put first, the visible signs of ill health are put first, the patient's welfare is prioritised, the family support structure becomes the focus, the patient's workplace features in the discussion. Does anybody want to offer an answer there? Yep. A? Okay, so... Okay, good. So one person said A, some people are saying B. Does anybody want to offer an explanation as to why B would be the right answer?
You have to diagnose the person first, and then help the person, and maybe tell them where to go, or tell them, or try to solve that problem, or support and help.
Okay, so what we said is the consequence of taking a reductionist approach is sort of reducing things down to their individual components. This person has gone from doctor to doctor to doctor, but no one's really been able to give her a diagnosis to actually help her, and that's because with the reductionist approach, it's the visible signs of ill health that have been prioritized. So this isn't saying that the other things are kind of neglected, but it's saying that under this approach, which you could fit under the reductionist approach, is in fact this search for the diagnostic features of her condition that have been put first.